take the blood from the venous system and return it back into the venous system, it becomes a venous ECMO. And if you do the same for an arterial system, it becomes a veno-arterial ECMO. The advantage of a veno-arterial ECMO is you can support the heart and the lung at the same time. For a veno-venous ECMO, it is most oftenly preserved for a respiratory function abnormality. So what are the indications for an ECMO? So obviously when the conventional therapy is failing, and although I like to iterate that there is no single number or criteria which helps in making a clinical decision, we have a lot of indices where we use oxygen index and PF ratio, but it is more how rapid the child progresses or the patient progresses and how quickly we are not able to gain the control on the disease pathology. That is where the indication for ECMO comes in. So for this child, what did we do? We initiated the venous ECMO in the bedside. Nowadays, we have access to the special kind of cannula. So if you go back to the previous image here, on a venous ECMO, there were two veins which were used, one for retrieving the blood and one for giving the blood. So with the advent of technology, we have a single cannula it is a dual lumen cannula where with the single access we can take in blood, and in the same access we can give back blood into the heart. So we have initiated ECMO on this child in the bedside on an emergency basis, and we were able to rest the lungs. We were able to ventilate the lungs in physiological pressures. So the lung gradually recovered, and eventually the child went back to being as playful as before. Again, a case 2 with this now a 6-month-old child, again a very similar X-ray where both the lungs are blown out with subcutaneous emphysema and bilateral pneumothorax. Again, we have initiated a bedside venous ECMO, and the child gradually became better. A different age group. This is a different scenario where a 24-year-old, he was a weightlifter. He underwent post-left pneumonectomy for hemopsis. But the other lung had got ARDS because of the residual glue. And his lung became worse, and eventually we could not ventilate. Again, we initiated ECMO on him, and he also became better. So nowadays we have a concept of ECMO retrieval. So some children are too sick to be shifted to any peripheral, to many main ICUs. So this is one child where the child was sick in Ludhiana. The whole team went in there. We initiated ECMO in the bedside of the DMC Ludhiana ICU, and we road transported the child from Ludhiana to Delhi overnight. So there are no pediatric trials as such, but ECMO for ARDS has been evaluated in adult population, and basically the data emphasizes what we already know. There is significant mortality reduction at patients who go on ECMO, and sooner the ECMO is initiated, the better are the outcomes. So what are our experience? Even though we started initially doing ECMO for cardiac centers like most of the people do, our first respiratory case happened in 2016. Since then, we have supported 29 children on ECMO for respiratory physiology, for pathology, and our youngest survivor for ECMO was a 1-day-old child. So when you look at the outcomes for ARDS, for 21 patients with ARDS, out of them 76% survivors were there, otherwise who wouldn't have made it. So to conclude, ARDS again is of the severe variety has got a rapid progression with a very high mortality, and early intervention actually improves their outcomes. And ECMO is definitely the last line of defense, but it's not a last-ditch effort, and timing is everything in its initiation. And nowadays, transport on ECMO is also feasible, and thank you.
Well said, Dr. Siddhartha. So the important thing to emphasize is what you said is the earlier we think about initiation of ECMO, the better are the results. Because most of the units or most of the clinicians, they think about ECMO or they introduce the topic of ECMO to parents when things are actually slipping away from their hands and lung has actually taken the brunt of it. So I think we all need to emphasize on the timing of ECMO, it seems. Thank you.
I think one message that definitely we wish to transfer from the podium to the audience is that every hospital which deals with sick patients having ARDS which can rapidly worsen should have a ECMO collaboration with a setup which does ECMO on a regular basis. Once you start communication at the right time, very important time gets saved. And time is of essence when you're saving lives in such situations. That's very important to have an ECMO center which is your pal. It should be your friend. You should be able to communicate with it very easily so that transfers and ECMO initiations can happen sooner than later. Thank you.
Any one burning question?
Just to be fair there, sir.
So, yes, I'll take that fiery question. Cost is always a brunt with ECMO. I think initiation costs are somewhere in the tune of 5 to 7 lakhs. And maintaining cost is maybe if any ICU has got a running cost of 50,000, the ECMO added on cost for maintenance will be by 20,000 rupees. So you initiate by adding 5 lakh, 7 lakh rupees, roughly depending on whether you require a VA ECMO or a VV ECMO. And maintaining cost goes up in your ICU by 20,000 rupees per day. So that most of the ECMOs that we have run are between 15 to 20 lakhs total bill. 15 to 20 lakhs in a patient who is most likely to die. And if we can save 76% of them, I think that's an effort worth making.
Thank you, respected Chairperson. Thank you, Dr. Siddharth. Now we move on to the session on genetics, and to chair it, it is my pleasure to invite the head of the Department of Medical Genetics at Sir Ganga Hospital, Dr. Ratna Duapuri ma'am, and the co-director of IVF at Ganga Hospital, Dr. Shweta Mittal ma'am.
Continuing with our academics at the Prime, now we would be hearing, I think, yet another one of the most important departments. I don't think there is any discipline where we don't need some kind of an opinion or consultation from the genetics department. We'll be hearing two speakers, Dr. Veronica Arora, who's the consultant at the Center of Genetics, and Dr. Swasti Pal, who is the associate consultant at Center of Genetics at Sir Gangaram Hospital. We are very eagerly waiting to hear very important take-home messages from you.
Thank you, ma'am. Good afternoon, everyone. You've all been a wonderful audience, and it has been a great pleasure for me to be emceeing this audience today. So we'd talk about the top 10 red flags in the clinic, in genetics clinic. So the evolution of genetic has been immense. 150 years back, when Gregor Mendel sat in a monastery counting peas, for us to today coming and seeing that we can change genetics and provide the children with therapies we never imagined before. So it is our responsibility to pick up genetic disorders at the earliest, because picking them. So genetic disorders do lay hidden in plain sight. They're not recognized easily, and not only in the genetic clinic. You see people moving around with cleft lip and palate, that is of a genetic origin. You see minor defects in the heart, like a ventricular septal defect, they may be of genetic origin, and underlying may be a genetic defect which can actually in later life have major outcomes and major problems in the child. So we need to identify accurately to prevent these disorders to not occur in their family later. So the common consultations in the genetic clinic that we see are in the obstetrics background, in the pediatric clinic, and also in the adult clinic, virtually covering all the aspects. So I'll be talking about the obstetric indications of genetic testing, and my colleague Dr. Swasti will take over the other two. So unexplained infertility, unexplained recurrent pregnancy losses, malformation, and family history of any genetic disorder. The one most crucial thing in picking up a genetic disorder is just that one sentence you ask your patient, is there any history of similar affected family member, be it autism, deafness, blindness, cancer, anything, you think genetic. So let's talk about infertility. We know that the commonest cause of primary amenorrhea in girls is Turner syndrome. That is a cause for infertility. It's easy to pick up a small test called karyotype, and we can pick it up. Klinefelter syndrome is a cause of male infertility. As we can see here, there is an extra X chromosome which causes some sort of learning difficulty and primarily infertility in males. Picking this up gives answers to the family, also helps in looking for other reproductive options and preventing the same disorder in other members of the family. The other disorder, Turner syndrome, it is not a stigma. We don't identify